My name is Trevor Perry Giles. I'm the Director of Academic and Professional Affairs at the National Communication Association. NCA is the largest professional association of academic scholars and teachers of communication. And with our over nearly 7,500 members committed to advancing the discipline of communication, we also attempt at NCA to try to provide services and other enhancements to the professional and academic lives of the people who are our members. One of those is the sponsorship of public programs at various places around the country. And we're thrilled to come to East Tennessee to talk about health, illness, and health communication in Appalachia. I will say that health communication is arguably one of the more important dimensions of our discipline. On all levels, communication scholars are committed to understanding the contours of public policy debates about healthcare and the extension of healthcare to more and more Americans, or fewer and fewer Americans. We are also, as scholars, committed to the enhancement and improvement of care providers and patient communication at every level. And so this type of public program is indispensable to advancing the discipline of communication and to enhancing the public understanding of the role and importance of health communication in all of our lives. I'm indebted to my colleague, Lakeisha Anderson, who I will introduce in a moment. Actually, I just introduced her, but I'll call her forth in a moment to moderate this discussion. But I'm indebted to her for the hard work that she and my associate, Jacqueline Riley, have poured into coordinating this event. I am also deeply grateful to our hosts at East Tennessee State University and the Department of Communication here for all the work that they have done. It's wonderful to come to Johnson City and to be with all of you today. So without further ado, thank you again for coming, and my colleague Lakeisha Anderson will take it from there.
Our goal with this program tonight is to engage in a discussion about the impact that living in Appalachia has on the health and the unique barriers to health faced by residents of the region. We'll also explore the ways that communication can impact health by discussing topics like health literacy, provider-patient relationships, and communication about specific diseases and conditions that disproportionately plague the area. We have scholars and community practitioners here with us tonight to discuss the state of health in Appalachia. I'm going to introduce them to you now in no particular order. So we have Dr. Katie Baker, who is an assistant professor in the Department of Community and Behavioral Health in the College of Public Health here at ETSU. Can you raise your hand? Yeah, that's great. We have Dr. Kelly Dorgan, who is a professor in the Department of Communication and Performance here at ETSU. Dr. Rebecca Adkins-Fletcher, an assistant professor in the Department of Appalachian Studies and assistant director of the Center for Appalachian Studies and Services, also here at ETSU. Dr. Sadie Hudson is an associate professor in the College of Nursing at the University of Tennessee. Dr. Amber Kinzer is a professor and chair of the Department of Communication and Performance here at ETSU. And Mr. Tony Lawson is the director of the PACE program at Mountain Empire Older Citizens in Southwest Virginia. The way that this program will work tonight is that we'll begin this discussion by talking about some of the ways that culture impacts healthcare here in rural Appalachia. However, we're interested in hearing from you as well. We will have a Q&A session immediately following this discussion that I hope you'll get involved with. Thank you for coming, and let's get started. All right, you ready? Okay, we want to discuss the impacts of communication on healthcare, but we can't discuss communication in Appalachia without a discussion about the unique culture of Appalachia. With that, I wonder how culture impacts access to healthcare in the Appalachian region, specifically when you consider things like gender, occupation, income, geographic location, language, and family caretaking.
So I'm the start. Well, I'll start. I'm Dr. Kelly Dorgan, and a number of my colleagues that I have had the deep honor of publishing with, including Dr. Sadie Hudson and Dr. Amber Kinzer, and I've had an opportunity to work with Dr. Katie Baker and then Catherine Duvall, who's out in the audience today. We've talked time and time again in our research about there is an intersection of variables. These variables aren't unique in the sense that other communities have these variables as well, but I think about it as a jigsaw puzzle. It's how they're put together. You may have the same pieces and the same shapes in the first generation Hispanic communities of Texas, but here maybe it's how, so for example, we talk about economics, education, we talk about geography, because you can't talk about healthcare if you're not talking about, frankly, sometimes the winding roads. You're talking about going over the mountain, but you're also talking about economics and having to take time off work to maybe go an hour to 2 hours away to your healthcare provider. And of course, historically, we have to look at Appalachia in terms of, and I'm really looking forward to Dr. Becky Fletcher talking about that. Historically, when we talk about Appalachia, we're talking about a system, a culture that hasn't necessarily been treated well by outsiders. And so when, quote unquote, government agencies or well-meaning healthcare providers come into the area, there might be some pushback and some distrust and mistrust, which we have found repeatedly in our own research. So that's where I would start.
Perhaps I should take the cue from Kelly proceed there. I certainly reflect Kelly's thoughts about the need to realize that Appalachia is not a homogeneous culture. We are quite diverse, and Appalachia as a region is quite large, extending from New York down to Mississippi and encompasses parts of 13 states. So considering all of that and the geological differences within the region, it's a mountainous region, but we have some differences in geology and microclimates. And so we have to expect that we're going to have differences in local communities and needs for people and how people engage with making a living and engage with each other and what that means in terms of health as it's related to environment and jobs. But it's also how they relate with healthcare. So looking at how they may be able to schedule appointments, get transportation to appointments, depends a lot on where you are in your life cycle, your age and your social mobility and class issues and gender issues. And so a lot of those things we have to consider and what that means for health and health access and how that helps give us a kind of a particular look at disparities within the region.
I'm from Southwest Virginia, which is a little different from East Tennessee in that we have no real large population centers, and we have lots of mountains, lots of small communities, and each one of those, the mountains separate these communities, and it's very real. There's great separation, and each community has its own identity. Over time, each community has developed its own healthcare system, like its own hospital, its own clinical services, whatever there is there, and they compete with one another. It's not a very friendly environment, that is all committed to creating access for the people who live there. So, and another thing that's lacking is referral centers for secondary or tertiary hospital services. They're simply not there. There's also very few specialty physicians, because they're attracted to larger communities. And so all of that has an impact on access to health care for people. Also, there's not a lot of large employers. So with insurance being based on through your employer, a lot of people know about the UMWA fund and about the coal mining industry and so on, and that was different. But for most people, they work for small employers and small businesses, and they may not have any access at all to employer-based insurance. So that's one of the reasons why there's fewer people who have access to health care through the insurance. So you have a lack of services that are available to people, so the services are not necessarily available, because of the size of the communities, and then you have a lack of access because of the way our insurance system works. And of course, then there's the public insurance, Medicare and Medicaid, that go into that, but a lot of the specialty docs won't accept patients who have Medicaid or Medicare. They want only the people who have private carriers. So that excludes a lot of people out of the healthcare system and the few specialists that are there. So those are all problems that I think relate to income, geographical location, occupation. And I'll throw in one more thing about family caregiving. I'm sorry, I'm not shy about this. Being a PACE stands for the Program of All-Inclusive Care for the Elderly. So it's a care coordinated system that gets lots of disciplines together to enroll people in a managed care organization. And all of the people who are enrolled are very frail elderly people who don't want to live in nursing homes. They want to stay in their own homes, so they have to have some kind of family support system. And so we do know a lot about family caretaking and caregiving, and there is a strong history of that, in at least our part of Appalachia, where people want the family to remain in the same community and in the same place, and they'll go to great lengths, in order to preserve that. And now I'll be quiet.
I'm just going to add to that. My interest in the panel is, I guess my contribution to the panel is related to issues of care and how that impacts well-being for the care giver. So we know, for example, that Appalachian families are a very strong component of social life and individual identity. We know that mothers are central to those families, and so we find that women are disproportionately responsible for making sure that everybody else's health is okay. And so I'm interested in looking at that, and it's critical because one of the things we face in coming from medical research and practitioners is trying to inform people about how to, and in particular women, how to care for the children, how to care for the elderly in their families. But there's a great deal of emphasis on information as the answer, and if we just informed people, if we just gave people enough information, everything would just naturally flow from that. And of course, that's not what's happening. And so in addition to whoever it is that is having health care problems or issues, we have the caretaker whose well-being is significantly impacted. And of course, at the same time, that person may also have their own health problems, but they're still responsible for taking care, managing the care of others. So I think the gendered nature of some of that caregiving labor is significant in general, but I think it impacts Appalachia in some very distinct ways.
And to piggyback on that, I think this is a place where intergenerational transmission of health beliefs and health behaviors plays a huge role. Oftentimes, if a parent grew up under a certain set of circumstances, we're going to see their children grow up under similar circumstances. So a lot of what we do is trying to understand, particular to the mother-daughter relationship, is how is mom communicating with her daughter about the experiences she had as a kid, and how is daughter asking questions, and what does daughter need to know in the event that we'd like to see a different outcome for her. I also had in my notes here that grandmother or mother is often matriarch of the family, and maternal endorsement of a given healthcare decision is usually one of the strongest predictors. Tosin Ario is my doctoral student who's graduating this May, and her dissertation, she looked at college students who had and had not received the HPV vaccine and found that for those who had received the vaccine and who identified as Appalachian, maternal endorsement was the strongest predictor of whether or not they had. So to piggyback on Dr. Kinzer's comments, I agree. The expectations of women as caregivers, as women, the ones who get a lot of things done in our area.
Right, and then
can take a
healthcare
toll.
practitioners knowing that, maternal endorsement is so significant means that a lot of the information distribution is targeted to them, so then they're responsible then for executing that or making sure everybody else is not eating the salt or going for the walk.
And across
or-
multiple members of the family and
That's
multiple
right.
generations. So
Right.
you end up being responsible for children and parents and husband and as we've talked about, in-laws too. You may then
Right, that's
inherit
right.
your in-laws as well.
That's right.
With regard to the role of women, my grandmother always said that no man other than my granddad was going to see above her skirt, and she wouldn't go to the health department or to a doctor for a pap smear. And it was only when she was of advanced age that we were able to get her to do that. Is that still a component is there still a hesitance among women to seek care, for themselves, do you think?
Yeah,
probably
that's a really interesting question. I'm a women's health nurse practitioner. So what I've found over the years, particularly since I've been living in this area, is that if women are going to choose one provider to see each year, it is likely to be an OBGYN provider. So, so I think that dynamic might be changing some. I also want to draw a little bit and circle back to Dr. Dorgan's comments about the intersection of variables. If you think about intersectionality theory, or like in anthropology, we consider that the same term would be syndemics. You can't easily, or maybe ever, untangle all of these socio-demographic factors that Lakeisha mentioned when she introduced this question. And so when you take all of that combined and then you put that in the backdrop of an ever-changing healthcare system, it becomes very overwhelming and hard for folks to navigate that. And so I think sometimes when, especially when there's a new diagnosis, people become very overwhelmed with how siloed healthcare has become. You have to go to this specialist, and then you have to talk to this navigator, and then you have to get a referral from this person. And so it becomes so overwhelming that folks often will just resign to not do anything. And I think that's something that the system has to consider and work harder at doing better at.
And maybe add to that, part of that is the multiple days off work that you may have to take to get care for yourself, or to take a child and then a grandparent or someone, and you just can't get that much time off work.
Or just the opportunity to make a phone call during the day.
Absolutely, and
Right.
so and that falls on this woman to do this, and it's incredibly difficult.
One of the things we haven't talked about yet either is the role of religion and people's religious faith and how that intersects with their seeking health care. And maybe it's not that big a deal in other parts of the country, or even in larger cities, but in the place where I live and in places around, like on Facebook, for example, when somebody is given a new diagnosis, the first thing they do is tell people, and they ask them to pray for them. And yet there's also, I still think, a lot of defeatism, in the idea, or I was trying to a moment ago to think of the term, what is it where you just resign yourself to your fate?
Well, it's been called fatalism in the literature.
Fatalism. And I think that's still a big part. If it's not, maybe not everyone goes to church, but I think that it's still in the culture, that we're raised in, and a big part of the way that we view the world. And so when we're confronted with these really heavy diagnoses, whether it's cancer or something else, then we tend to immediately, start thinking about death and sort of preparing for it, rather than, confronting it and and trying to do our best to survive and cooperate and go past all the barriers that you're talking about, with trying to navigate a complex system.
Well, and I love what you're saying, Tony. Raising the issue of fatalism. Now, Sadie and I years ago did some research where we went into Southwest Virginia and then Northeast Tennessee. And what we found, instead of that old cancer fatalism, was more of a healthcare fatalism. It's that I think people understand that it's not necessarily more information. It's that that cancer is survivable, for example. But it's just you have to navigate this increasingly hostile system, and I think, Becky, you said it so well. You have to take time off of work, and if you're investing in self, that feels selfish. But now, if you could take mom 2 hours away, that might make a little bit more sense to navigate this system. But I think that there does tend to still be some healthcare fatalism.
And I think that in another way, we tend to think about older people if we think about some of the chronic illnesses that affect our population. But then with younger people, I think when they're coming into a labor market and they haven't achieved much in the way of schooling. So they may have just barely scraped through and got a high school diploma, and they have no jobs. There's just no jobs to go to, or they may come from families that have been on Social Security disability for a generation or two, or who managed to get their child, who might have been a product of divorce, into to get them listed as disabled because they have ADHD or they have some other diagnosis. And we're seeing children who are being raised on disability who are then moving into disability roles without ever going through through employment. And that's a kind of defeatism. It's like have they achieved something by not having to work? And is that how limiting is that on your worldview?
I wanted to circle back to something that you mentioned a few minutes ago, Dr. Jordan. You mentioned distrust of the medical system. And fear, lack of knowledge, distrust have all been variables that have been cited as primary barriers to medical care in the Appalachian region. So I was wondering if you could tell me more about the fear and distrust in this area, particularly with physicians, and how you think that's communicated.
Oh, I'd be glad to start, but I'm gonna need this team up here to help out. Number one, I think it's important to first go, it's not distrust of everybody. As we've talked about, and we have sometimes family members, what we've identified is that trust of family doc to handle everything, to do everything. But that fear of work, not fear, but that suspicion, I'm trying to figure out what word that I want to go into the specialist. And we've talked about leaving the mountain, leaving the community, and I think Tony really touched on this nicely. Not only a feasibility issue, but also just now you have to go put your hands in your most vulnerable time. You're separating yourself from your support network, whether it's the church, whether it's the family, to go elsewhere. So, and then I know that, again, in some of our early research, we identified that, matter of fact, in focus groups, we were asking people, who do you trust most? And doctors were way down on the list. It was kind of scary. Mothers were at the top of the list. Neighbors even atop the list. It was kind of like pastors, and then doctors way down here. So I think that there was some concern, still seeing that kind of suspicion of someone other than the family doctor. Someone chime in here and.
So I wear another hat in addition to assistant professor. I'm a county commissioner here in Washington County, and I serve on the Employee Compensation and Benefits Committee. So we have to make decisions about county employees. There are about 460 county employees, and we have to make decisions about their health care, about their health insurance policies. of course, using taxpayers' money to fund those premiums and to cover their costs. So what I have noticed, at least between employee and pseudo-employer decision makers, there's a distrust between employee and the person making decisions on their behalf for their health care. So I think they ask themselves, do the people making decisions about my health care, making those decisions on my behalf, have my best interest in mind when they're making those decisions, or are they making decisions that are best for the budget? And I think our decision makers are probably very torn between the fiduciary responsibility they feel like they have to the taxpayers and providing their employees with the best health care. So I think the competition that Tony brought up among communities is present across silos, right? Because often people's access to care is decided by their employers, or in the county's case, by the taxpayers and the budget. So I think that we default to improvements in health literacy, and we default to the patient's responsibility in getting some skin in the game in healthcare, right? In a recent Compensation and Benefits Committee meeting, we said, well, let's up their premiums a little bit. That way they've got some skin in the game. And with the assumption that health behaviors would improve as a result of having to pay a little bit more every month for their family's health insurance coverage. And for me, that feels like a disconnect between the systemic changes that our communities deserve and really what's happening on the ground. So I think that it's not necessarily distrust of the healthcare providers, it's more of distrust around, will my access to care be taken away by someone who doesn't have my best interests in mind?
It's interesting because I see in my own family, my father has Alzheimer's, my mother's had several strokes, and my two sisters are working to manage their care. And the care of both of my parents is really taking a toll on my sister who lives there. And she already has a distrust of, well, pretty much everybody. I mean, this is a very fatalistic, everybody's trying to, nobody's going to get me kind of way of living in the world. And so healthcare is not immune to that sort of approach. But so she's suspicious no matter what any of the doctors say. Primary care, specialist, the trip to Asheville, they live in Franklin, North Carolina, and so that stands in the way of the healthcare professional being able to communicate these messages to her or to my parents. So if the biggest distruster is the mediator, and the one who's responsible for getting them to and getting the prescription and that sort of thing, then that certainly becomes a problem. Conversely, my parents sort of oscillate between great distrust and disregard of healthcare practitioners. So, no, they wouldn't, for example, challenge anything that the physician would say, or even ask questions, or even say, okay, so, all right, so we're taking this and that's going to do what now? And so why is it that this isn't working? I mean, they can't, they're older, and so being able to sort of think that through is complicated for them anyway. But they would not come up against the doctor. And to them, asking for clarification and demanding that you get the information you need before you leave that office feels like antagonism. And so when any of us do it on their behalf, it unnerves my mother, and then so it really is very complicated. So there's this distrust, and then this disregard if things don't work. I mean, they want science to be more perfect, medical science to be more perfect, and the idea that we're trying these different medications, we haven't found the one that works, and we didn't go to this super expensive new one for $100 a script. We went to that last, but I think when they can't afford it, they don't want to confront that they're not taking care of their health because they can't afford it, so then they just distrust the doctor's assessment instead of saying, we trust him and we're just gonna not do it, because that wouldn't make any sense. So unless I totally don't believe what he says, in which case, then I'm the smart one. So that the trust and distrust is just a really very interesting dynamic. The other thing they won't do that they feel is challenging and is manage their appointments in a way that is, to organize their appointments in a way that's manageable. So the people in the office, of course, because they've got a million people to schedule, will say, how about Tuesday at 3? And they go, okay. And then, so then that's when they go. And then if another doctor says, well, what about Thursday at 4 and Monday at so then there's no ability to understand or willingness to say, I'm doing doctor's appointments on Tuesday and Thursday. That's when I'm going into town. Can we do Tuesday, Thursday? Really, so like every day is taken up with some aspect of it. And then there's going to the drugstore after and waiting for that script to be filled. So this relationship with the physician and sort of not really struggling to navigate that in an informed way and in a self-preserving way. I don't think, honestly, that it's ever occurred to my parents to say, yeah, well, we're not going to come every day. So we're here today and we'll come Thursday because we've got another appointment in town that day. So can you, okay, then how about next Tuesday? So just not being able to do that. And then, not surprisingly, they're exhausted. From all of this running around, and then now we have to go to Asheville, but Dad also has this appointment at another time, and so instead of saying, no, I can't go to Asheville that day because my husband has an appointment here, it's, okay, we'll just figure it out and just exhaust ourselves, and then no wonder we don't have any trust.
I think part of it too is that people are very passive in their relationship. It's like, and that is evidence of great trust. It's like initially entering into a relationship, you may be very passive. You don't, this is sort of speaking from my experience and people my age and older, they just go to the doctor. They expect the doctor to know her or his business and to know what to do in order to bring them back into a state of health. Right. So you are very passive there. Then if though it doesn't work out, then you feel as if you've been betrayed, yes, by the system. Right. And, that doctor doesn't know what they're talking about, or you just totally reject everything rather than, and part of it may be that you're not coming into a relationship that's an equal relationship. It's very unequal with regard to health knowledge. We talk about health literacy, but it's also just the knowledge base. You have to trust because you don't know. Right. And then you hope they do. And but there, that I don't know, that sense of betrayal. And then if you don't have, it's like I went to a specialist, and within a 10-minute meeting, by the time I talked with her, she had referred me out to 4 different other specialists that she wanted me to go see, and I said no. I said that's just not necessary. I'm not going to go to to this place or that place for all these things. And it was like it truly wasn't necessary. But it was like I think most people would do it.
Right, and I think there are tendrils to religion there. And a regard for authority, and if you have someone who's, you're supposed to be respectful of authority, and that's part of the larger, the larger culture, and you have this person who you're supposed to trust, and so then you just do that until it doesn't work, and then they betrayed you, so then you don't.
And think about, I've known a lot of nurses over the course of my career, and and some of the people who trust doctors the least are nurses who have worked with them, cheek to jowl, because they see what happens, and and they see the mistakes that are made. They see all these other things, But that's always interesting to me is, to see that sometimes the least compliant, they call them, patients are the people who know the most about the business.
Yeah, it's very interesting. I see patients at Pikeville Medical Center in Kentucky, Eastern Kentucky. So what I figured out from working there over the last 7 years is that the really beautiful quality that in the Appalachian culture is this love of relationship, this relationality. So we were talking about before the panel, I grew up in Wisconsin. I don't have a Southern accent. So patients walk into a room, they know immediately that I'm a Yankee. And so what I figured out, and they'll ask, whose girl are you? Like, who are you? Whose wife are you?
Right.
Whose daughter are you? Whose cousin are you? They want to know who I am, because they know, really without asking that question, that I am not from Appalachia. And so I figured out over time that the more, as healthcare providers, we do a terrible job of relating to patients because we don't have time, right?
Right.
You're supposed
that's
to see X, Y, and Z
Yeah.
number of patients over a 6-hour day, a 7-hour day. You're supposed to see 25 people. We don't do a good job of that. So the first thing that I do before I talk to anybody about why they're there to see me is ask them, how are you? Tell me a little bit about your family. And I ask them those relational pieces. Tell me a little bit about who you have with you today. Why is that person important to you? When they see that you're okay and they can communicate with you and be honest with you, that interaction goes so much more smoothly, particularly when you have to give difficult information. So, and there have been other studies here about, particularly in oncology, breaking bad news, or even breaking bad news a second time. So someone has cancer, giving the initial diagnosis is very hard. Telling people that they have a recurrence is even more difficult, because it's really kind of shattering, any hope that they had that whatever treatment they were undergoing was working. So if you have that relational piece in place with your patient, it makes that interaction go more smoothly. And it's okay as the provider also to express emotion in that interaction, which makes you real. I think the other thing too is that in Appalachia we see a huge influx of international medical graduates. And so then patients go to appointments and they worry about, well, who is this person that I'm seeing? And I don't know if I'm going to be able to understand them or if they'll be able to understand me. In so many ways, it can be so simple in terms of going back to asking folks about just really what is it that's meaningful to you, and what is it that you hope to learn in this appointment today? Who sent you here to see me? What is your understanding based on what they told you about why they wanted you to come see me? Get the foundation right as a provider and build from that, because that's where people will really start to connect with you. So I started out at Pikeville with, over the first 2 years, maybe a 70% no-show rate in my appointments. So that's no good, right? I'm driving 2 hours there, getting there and seeing one patient and trying to figure all of this out. Now what I see is I have probably a 20% no-show rate. And it's funny because I've had to kind of calculate this over the years, to say like, hey, it's really a good thing that you continue to contract with me because it's getting better, it's improving. But I'll have patients now that self-refer and say, well, do you know such and so, because they told me about you and we have a really similar cancer family history in our family. And after they talked to me about what it is you helped them with, I thought maybe it would be a good idea for me to come see you too. And I brought my mom and I brought my daughter. So can you talk to all of us? So then it goes back to the intergenerational piece of bringing the women in, because there's that responsibility that I need to know for myself, but my mom needs to know, and my daughter needs to know, and everybody needs to know to be able to take care of others.
Right. I think so often the patient is there not necessarily for their own care, but for their family. My dad was diagnosed with lung cancer in November, and so we've been to a lot of appointments, and every time that a provider asks him a question, he says, is that okay with you? To me, because he's not going through chemotherapy for himself. He's going through chemotherapy.
Your father asked,
yeah.
is
Father
that okay
asked.
with you?
Yes, yeah, oh, I'm sorry, yes. So when a provider asks him a question, he then turns to me and says, is this okay with you? Is this the decision you want me to make? Because, again, I don't think he would have chosen this course of treatment had it not been for me, had it not been for the responsibility he feels like he has to his family. And I think that that's true throughout families in Appalachia, especially if a male is sick. I guess if a female's sick too, they want to get better for their family. I'm not sure that that locus of control is internal, or that motivation is to fulfill X, Y, Z personal dreams or bucket list items. It's more about, I don't want to leave behind my family members.
Right.
And I want them, this is bigger than me. This is about them.
Yeah, there's so much to piggyback on here. So in Appalachian healthcare, there's a very long history to look at the professionalization of medicine and healthcare, and you can trace that story here in the region. And so how the idea of authoritative knowledge kind of comes to mind to think of what everyone is saying here, where, you know, the medical system in a sense has and patients have co-created this relationship in a sense where, you know, the provider is the authority and the patient should do what they say. Otherwise, they're labeled as non-compliant or fatalistic. But perhaps we can also see that as agency,
Yes.
where they
Right,
are
thank you.
taking control in these
Right.
ways. And so they're not just these malleable patients who are going to do things. Ultimately, it's their life. And, you know, so there are many ways that, in my research, I've heard people talk about distrust in other ways, and I wanted to kind of end my comment on the idea of means of payment. So I've, you know, had a lot of interviews with folks with Medicaid who've talked about not being able to get an appointment or having to wait months because a provider will only have 4 slots a week for a Medicaid appointment, and you just simply can't get in because of your means of payment. You take a child to a pediatrician and you're on Medicaid to get their vaccinations. And there are 2 stacks of the same vaccine. One is paid for with state Medicaid money, and one is paid for by private insurance. And if you have the wrong means of payment for the stack that's out, they're out of that day, your child can't get the vaccine even though they have plenty in there. So those are, you know, problems with access and causes distrust. So now I may or may not be able to bring my child back another day within a reasonable time frame for a basic vaccine. Other folks with very good health care worry about overtreatment. Their provider saying that they have the gold card and want to refer them to 4 specialists from one visit and may stand up for themselves or their family members in those ways. So it's an incredibly complicated picture.
Something that I want to say really quickly, and I would love Becky, you, or Sadie or Katie to chime in on this. One thing I found that I have found in interviews and focus groups, and I think you'll really be able to speak to this, and also historically, Becky, is when we talk about distrust of healthcare, one practitioner tends to be exempt is nurse from distrust, and especially around human papillomavirus. We've talked about that, and the HPV vaccine or the cervical cancer vaccine. But nurses tend to kind of, I think, escape that sense of distrust that doctors sometimes or the entire healthcare system is not. And I don't know if it's our history of circuit nurses on top of it. I don't know what that history is, or if it's a gender dynamic. I don't know what that is, but it's striking to me that time and time again nurses get named, other than mama, nurses get named as a primary source of information.
Well, think about who's assuming the bulk of the responsibility of patient-provider interaction.
Right.
It's going to be the nurse. The nurse is taking your history. The nurse is doing your vital signs. The nurse is probably the person who remembers from visit to visit
Right.
why you're there,
Right.
Without having to reference an electronic health record or a paper chart or anything else, because that relational piece is there. I do think there is perhaps a gendered component to that as well. But it also goes, Tony's comment about nurses even being critical of physicians. Well, so, is that just a knowledge base in terms of experiences with those providers, or, or being called upon routinely as somebody who's trusted, who's an expert. So, I get questions all the time about, hey, do you think this person's okay to go see? What is your experience with this provider? What do you think about that person? Now, you're not going to see those questions being asked across physicians, and maybe not even nurse practitioners if they're functioning in a role of a primary care provider. But if you're a nurse in a community, you're held to be a trusted individual who's supposed to have some knowledge, some answers to these questions.
Do you think that that part of it has to do with where the nurses are from? You mentioned a lot of doctors are from places other than the local community. And the nurses tend to be people who are local and who have those connections and
Absolutely.
can make decisions. But I think that also, what's the old saying that doctors diagnose and nurses heal? It's like there's different roles for the professionals who are involved and different approaches to patient care.
Holistic care is the hallmark of the nursing profession. So, again, I think building on the cultural values with relationality is a critically important piece.
I was thinking about something else that I know we're talking about Appalachian culture, but I think there's part of. I was at a meeting with it was the State Cancer Action Group or something. It was years ago. What we were doing was trying to think of a way to put pressure on the State Insurance Commission to require insurance companies to cover colon screening, and they didn't cover it at that time. So, an oncologist from Northern Virginia got up and spoke, and she said that there was no point. Let's see, I was sitting there worrying about all the people who didn't have insurance and saying, why can't Virginia require, if they're going to cover colon screening, why can't they, require Medicaid and Medicare and require it to be a public thing? And what about the people who don't have insurance? And she was saying, well, if they don't have insurance, then we don't screen them, because if people don't have insurance, they can't get treatment, so there's no point in screening them. And that was the most callous point of view that I'd ever encountered, and yet it was one that was there among these people who were going to make decisions based purely on business about what insurance companies in Virginia would cover, and that struck me as being alien. So I wonder how much of it comes from this imposition of a medical or business or healthcare industry frame of mind on a culture that is just totally
and that
different.
frustrates me, Tony, that you say that, because I remember going up to remote area medical and hearing people say, if I go and get screened, and some people know in the room, I still carry this image, this conversation with this one woman whose breasts were so full of tumors. I don't know if they were benign. I don't know if they were malignant, but she couldn't even wear a bra anymore. And she was explaining to me that the reason she doesn't go get screened is because even if she found out, there was nothing she could do. And so we're out in the field, of course, trying to say, no, there are programs, there are ways to engage the system. I know it's hard, but you're saying right here, that just struck a chord with me, that so many times the people out in the field that we encounter who are saying, what does it matter? Why do I get screened? Because there's nothing I can do.
And it's very piecemeal. The programs that exist are not sufficient. They're piecemeal, and there's no intention on the part of policymakers, to make care accessible and affordable to people who don't have the means to pay. And they talk a good game at RAM, but that's the only time anybody ever sees them.
Well, and she was talking about she would have to rent a car or get a cousin to take time off of work. So if she had to take time off work, her cousin had to take time off of work. And as you know, now we're talking about a 1.5 hour, if not 2 hour drive just to get screened. And that's not even to engage the entire system.
In talking about access and this idea of trust, I think that was actually what you said a few minutes ago, Rebecca. Access and trust, it struck a chord with me. Do you have any opinions about how the culture in Appalachia impacts acceptance of non-traditional methods of medicine, like drone delivery of medication or surgical procedures happening online? I know I've read a couple things recently that happened in Wise County, a surgery that was performed online. The actual surgery took place in Wise County, but the doctors were linked via satellite to UVA. And so they did the surgery that way so that the person could receive care because they couldn't go to Charlottesville. And I've recently heard about some drone delivery of medication in the Wise County area. So I'm wondering if you feel like there's a barrier that might not be able to be gotten over with that, or if you think that's something that they're amenable to here.
So we offer telemedicine to county employees, and at first it was just a very slow uptake. Naturally, people wanted to continue going to their primary care physician, but the telemedicine company did a pretty aggressive marketing campaign, and before you know it, over 100 employees have used telemedicine, mainly for seasonal allergies, pink eye, minor and acute conditions that can be easily treated that way. And it's fascinating to sit in that seat as a public health person and a county commissioner, because you see that telemedicine has saved the county several tens of thousands of dollars. And it's totally free to employees. So I think that it just takes a few of those innovators to try it and then spread the word. So I would say that Appalachian communities are amenable to that service, to that technology. I know that several school systems use telemedicine for their school health clinics. So I think it just takes a few people, a few schools to jump on board and have success with it. And at least for treatment of those minor conditions, I'd say people are open to it.
So what surgery was that was performed?
I can't remember, and I want to say that it was an eye surgery, but I really can't remember at this point.
And it was an ophthalmologist on this end? Who was on this end doing the
It was an
wielding the
ophthalmologist
knife?
on this end who was performing the actual surgery, but the cameras all were linked to doctors in Charlottesville who would tell that doctor how to perform the surgery.
Did you say drone delivery of medication? So here's what I think about that. My mother would dig that in a major way. And she would not care if it's funky and technology and whatever. She was just like, oh, you're gonna bring it to my house? Whatever, bring it on. My dad with Alzheimer's, with little drones flying around, seriously, like he would be mortified. I mean, he wouldn't even go on the computer because they'll see you in there, kind of thing. But so that we're gonna have to deliver it like down the street at my sister's house or something because my dad I think he will just really, he'd flip out. I mean, he doesn't, we see sort of paranoia and in Alzheimer's patients, and they're out to get me, they're, conspiracies, that kind of thing. And I mean, it's really serious, and that wouldn't work. That's interesting.
My Alzheimer's is still very mild, but but I wouldn't doubt but what I'm going to get there. My mother has Alzheimer's, but in thinking about the drug, I still see that as, I mean, I work for a place that has 100 frail people. We can, and one of the things we have to do is send a nurse out, for a visit to help set up their medications. Once a week or twice a month. And, there's all different kinds of ways that we work with people. I would love to be able to to send drones out and deliver it to people's houses, because it would save time and money, to do that. However, I just really, people in Southwest Virginia love to steal medicine.
Yeah, right.
And they love to get any kind of medicine that they can from a doctor. And if we had drones out, we would have people with all sorts of nets and things trying to get
Shoot them down.
And guns! That's what my dad did too. He'd be like, down. Woo! Saved us all. No, Dad, you did not.
Well, but
what do you all think? I mean, and yet that delivery at RAM of the medication is being held up as bringing Wise County into a leader of the 21st century technology and all this stuff. But it's like, what's the next step? How can it really progress from there?
But I do think it's, as Katie was saying, the idea is the more the providers normalize technology enhancements in patient-provider interactions, I think the more people will see that there's a benefit. Now, I can say for sure that my patients in Kentucky would much rather have a telemedicine interaction than for me to send them to Lexington.
Right.
Would much rather have that.
Right.
And so, it's about how you approach it, how you introduce it. This is something that we're doing for your benefit. We're bringing the specialist to you. These are all things that we can do now with all of this technology that we have. And everybody has this, right? If you look at some of the most recent research, I do a lot of research in digital storytelling. I've done electronic delivery of surveys and different instruments, measures for some of the research that I've done. Funders will always say, it never fails. There's some reviewer who comes back and says, you are from Appalachia. There is no way people in Appalachia are going to respond to an electronic survey. Well, but wait a minute. Even if you don't have a computer, you probably have a phone, and you probably have a 3G or 4G connection, which connects you to the internet. And you can access the instruments. You can do a telemedicine interaction. So when I turn around and say, our response rate was 55% on that survey, and we delivered it purely electronically, people are blown away.
I see Kelly Foster here, who runs the Applied Social Research Lab here, and we collaborated on a study last year, and we found like 84% of mothers in Appalachia are on Facebook.
Absolutely.
So it's not a technologically, there's not a barrier to technology like we might think.
I just want to say, I think that what we're touching on too is what we all face as scholars up here and practitioners, is that how do we talk about Appalachia? How do we talk about the uniqueness, the potential uniqueness of Appalachia without buying into those old stereotypes that we all get, whether it's from the journal reviewer, whether it's from when it gets scored in terms of a grant, that, well, Appalachians, I guess can't get out of get off their mule long enough to go on their electronic box. And so I think a lot of us are just really sensitive to the fact that, yes, there can be some truth, there can be some barriers, but there are these opportunities that I think what I was struck by are people, again, who are outside of the region, who say this couldn't possibly happen And time again, what our research says is that these interventions, these research projects cannot be designed outside of the region. They must be designed within the region with an understanding that this is a complex culture with people on Facebook and doing digital storytelling and responding to telemedicine.
When you talk about telemedicine, are you talking about several different kinds of communication? When I think of telemedicine, I think of and we have a telemedicine connection with UVA, and we've used it in different ways, but it's it takes a particular kind of line, a phone line, a T1 or something like that, and, lots of bandwidth, and we could do diagnoses, we could have different kinds of specialists, there, but to tell the truth, we faced problems of we were using it for psychiatry to start with. And what happened is we simply had logistical problems of getting when there was a psychiatrist with an academic interest in suicide in Appalachia, we had no problems. When he left and went someplace else and somebody else came along who wasn't so interested, we were just linked up with residents, in psychiatry, and they might be there, they might not, and they actually had they had a higher no-show rate than our patients. So we just stopped and started bringing people to Kingsport again. But then there's other kinds of communications that could be done through phones or in other ways that are very helpful and are used in home health a lot. So I think and the biggest thing has been to jump from requiring landlines to getting it done through cellular technologies. So.
When you have patients who come and they use a telemedicine service, do they still have to come to the office before they can use the telemedicine service?
They did when we were using it, yeah.
So access could still be a problem.
Well, no, we provide transportation and everything.
Oh, okay.
With PACE, it just does everything for people.
Right. I actually wanted to loop back to something that Tony mentioned a minute ago about substance abuse. And while it's not unique to the Appalachian area, it's something that disproportionately affects Appalachians. So I wanted you to maybe speak to us a little bit about how that is being addressed, maybe how we communicate about substance abuse in the area, if there's any media campaigns that specifically focus on substance abuse and how to prevent it or to overcome addiction in the area.
I think every type of resource you could imagine is being thrown at that problem. On a local level, for example, the county did not offer an employee assistance program to its employees prior to just a year ago. So they didn't have access to counseling, or their families didn't have access to counseling in the event that they needed to work through substance use or addiction issues. The mayors of the 8 counties of Northeast Tennessee have gotten together to talk about how to address this issue. There are large public open forums about medication-assisted treatment facilities in our area. So I don't think that you could approach anyone in Appalachia, ask them about the substance abuse problem, and they would say, "What are you talking about?" I think we've reached the tipping point at which everyone knows that that's a public health issue facing our families. And now I would go as far as to say we've reached the point at which most decision makers are ready to do something about it, whether it's through employee assistance programming or supporting the research and program development we do here at ETSU. I think you're seeing a lot of support for how to involve, for example, faith-based communities in the effort, how to involve schools in the effort. Our county school system has agreed to a prescription drug abuse prevention curriculum in the schools. When we talk to school health personnel, when we talk to mothers in preparation for a large grant we have from the National Cancer Institute, we ask them what are the top 3 concerns for adolescents in your community, and prescription drug abuse was number 2. So just behind obesity and its complications. So when I was growing up, my mom was addicted to prescription drugs. And it was very hush-hush. You know, we did not talk about it. That would have been in the late 80s, early 90s. It was not a topic of conversation like it is now. And I think that those open lines of communication are accelerating our ability to do something about it. More than the silence we experienced several decades ago.
And this is not my area of research, which explains why I jumped in here. But that's it. That's all I want to say.
But don't let that stop
Don't
you.
let me stop. But I do want to. I want to touch on something that Tony said earlier about religion, because I know that there are scholars like O'Keefe over at Appalachian State University, not giving them a plug or anything, but talking about that part of the challenge with talking about prescription drug abuse and opioid in particular is that so much of it is still hush-hush because of the wrapping up of mental health and the intersection of mental health with religion and this, if you're just strong enough in your faith, if you're strong enough in the Lord, that you would really be able to pull yourself out of this. And so it really creates one of the primary organizers of health conversations being, and I do mean one of the many, 80 sub-denominations of Baptists throughout Appalachia, really promoting health-based communication, except around this area sometimes, that there can be a silencing, and that's wrapped up in the silencing around mental health issues, and that if you were stronger in spirit, if you were stronger in the Lord, then you wouldn't succumb. And so I think that might also still be playing a role in prescription drug and the silencing and the shaming and stigma.
Since I don't know anything about anything,
Well,
let me
I started it.
Jump right in. Go ahead. Lay it out.
jump in. Not only religion, but I think another institution we all think about, is the family, and which is a great strength, in which you talk about how important the family is, relationships in medical care and accessing it, but the family is also something that squelches talk about somebody being addicted, or that somebody is being, has been arrested or anything like that. I mean, that the pressures are immense, to keep it quiet.
Yeah, I mean, are we talking about substance abuse and opioid abuse? Absolutely. Is it still highly stigmatized? Absolutely. And the biggest barrier to making a difference is in the way that we treat it, because we consistently look at substance use disorders and treating them as a one-size-fits-all. So if we just take the premise of what we've been doing with AA programs for decades and apply that to substance use disorders, I'm sure that will work. But if you think about it, think about how, like, anytime you've heard, everybody knows somebody who has abused drugs, yes? Pretty much?
Yes.
Yeah. So how do you hear substance use disorder referred to? What are people called? They're an addict.
Drug addict.
You have to suspend your identity because you're no longer a person, you're an addict. And so and you can't go through any kind of treatment that would allow you at all to use methadone, right, for recovery. Because you have to follow an abstinence-only premise because you're an addict, and you're going to be an addict forever.
And
That's
you have
a
to stand
huge
on the
issue.
street. You have to stand on the street in front of everybody, in front of the methadone or the Suboxone clinic.
Absolutely.
And everybody drives by and looks at you.
So
and
you
sees
don't
who you
have
are.
any power to be anything other than an addict once you're an addict.
Right.
And it's not, is that first use a choice? Yes. After that, based on your biology, it is an illness, and we don't address it that way. And we can't treat substance use disorders as a one-size-fits-all, just like we can't treat anything else like a one-size-fits-all. We talk about all of these wonderful programs in patient-centered care, and yet where do we fail hugely? Substance use disorders, mental health, all of that is interrelated, and it's a tragedy. We have more people dying in this state from opioid abuse than we do car accidents. It's horrible.
Well, what, we're the second state, or the, what are we, we're number two in the nation, right?
And Johnson City was just rated as 9th in the country, and as far as opioid abuse. But, and this quote, I can't remember where I heard it, but it really, I keep coming back to it, but it's that opioids came to Appalachia because Appalachia was in pain. And so think about the coal industry, think about, you know, all of the types of work that people do here where they sustain injuries and they're prescribed painkillers. And yet our providers have really no good working knowledge of how to manage that. Pain management is a very, very new subspecialty.
Right.
So you've got providers out there, particularly here where you have a lot of rural areas and very few specialists who are trying to manage pain and have no idea where to start. And that's how things get going. And you're trying to add something, take away something, and providers feel helpless as well.
And they also feel like besieged, you know, by law enforcement, and you know, and because they're afraid that their licenses are going to be removed. I know doctors who have who just flatly refuse to prescribe narcotic pain relievers, and you know that's not the solution.
It's not the solution.
You know, I don't think. You know, you have to. Some people need it.
Yeah, increases in conversation haven't necessarily led yet to increases in access to care.
Yeah.
That's for sure. I think at one point I was working with a student on a project and she was digging into the community and what sort of access pregnant women had to treatment. And I think there were 12 beds for pregnant women in Johnson City. Wow. Pregnant women who were experiencing addiction. So it's a fascinating landscape. I do think, though, that 2 decades ago, we wouldn't have had people up at a town hall hollering about medication-assisted treatment. You know, I think that people are showing up to have the conversation that used to be so quiet. Even if it's in opposition, they showed up to have the conversation.
But yet, Tennessee was the second state in the country to criminalize substance abuse in pregnancy. Thank goodness that sunsetted. I mean, you take somebody who's in crisis, who's pregnant, and then you make them fearful of what's going to happen when they go to prenatal care.
Right.
That's tragic.
So much of all of this discussion is couched in personal responsibility. You know, so it's the blame the person, blame the addict, and there is very little attention to Big Pharma and their role in this. And so it's very much about an individualized blaming and not enough treatment facilities.
Right.
And sometimes they're not close to home. So the facility may be a few hours away, especially if it's a pregnant woman. So getting in and getting access, getting it paid for are other very large issues. And then we don't pay attention to how prescription drugs have really become a subsistence strategy, an underground economy. So it's not just about individuals in healthcare. This is how people are trying to make ends meet, and in some cases pay for their own addiction, but in other cases to pay for basic needs for children and for families by doing this, and that isn't addressed as well.
Yeah. I hate to jump in here, but believe it or not, we've been at this for an hour and 15 minutes, and in order to move forward, I want to ask you guys to answer 2 questions. It's one question with 2 parts. So I'm going to ask you to maybe try and do this in 15 minutes, if you can.
Look at you.
It's a big question.
Sure.
First,
15 minutes each, right?
no.
I can
Each of
handle
us
it.
has
Although
15
I know
minutes for
she
each
could do
question.
I have lots and lots of questions that I could continue with, but we're going to have to move on. First, I'd like each of you to tell me one thing you think this region does particularly well in terms of providing support or access to health, something that is unique to Appalachia if possible. And then I would like you to tell me what improvement in healthcare you think would best benefit Appalachian residents right now. Whether that's transportation, better transportation to appointments, improved health literacy. If you could give me your thoughts on those questions.
So in terms of improvement in the system, so I told you about my personal experience. My dad was diagnosed with lung cancer, which is not terribly surprising. Greene County has the highest prevalence rate of lung cancer in the state, and I'm from Greene County. So when he was diagnosed, we had to go to a pulmonologist. There was one pulmonologist in town, and from there was going to be a referral to the oncologist. And at that point, the pulmonologist couldn't even remember the oncologist's name. And that is the point at which I said, okay, I'll take it from here. I'll identify an oncologist that we can work with. And for months, we traveled back and forth from Greenville to Johnson City so that, he could see the provider that I had chosen. However, had our services and systems been aligned with our public health surveillance data, we would know that we need more pulmonologists and oncologists in Greene County to specifically treat lung cancer. In fact, if there's any county in the state that deserves those resources, it's that community, because they're suffering. The mortality rates for men and women are highest in Greene County when it comes to lung cancer. So I think a focus on aligning our services and resources with our public health surveillance data is really, really important for policymakers moving forward.
I'm going to jump in. What we do well, and several people in the audience know what I'm going to say. I think a lot of organizations, a lot of practitioners have done well what Katie and Sadie have done, tapped into, is that, as well as Tony's organization, and that's storytelling. I think we've used storytelling well, and I think of Mountain Laurel Cancer Support, for example. And the digital storytelling that's going on, this understanding that sometimes this just basic way of talking about navigating health through stories becomes potent. And we've seen that time and time again in our research of the power of storytelling, especially when it comes to helping people see their way over healthcare obstacles. I guess what I would, if you ask me what I'd like to see tomorrow, I'd love to see, and I'm hoping you get on this, I'd love to see some digital storytelling on overcoming some of these barriers to access. And I'm thinking what Katie said, a number of people in here know this experience of trying to get access to a specialist in this area. Everybody in this room probably knows what it is to have a very scary diagnosis and to be told, or a painful diagnosis, and to be told you have to go see a specialist, but there is only one in town, and you have to wait a month, 2 months, 3 months, 4 months. And I think that this goes back to that healthcare fatalism. I think a lot of us smartly just opt out of the system then, and we say, you know what, I think I'll live with my uncertainty. And so I think, what if we did have stories of people who successfully navigate the system, and this is a challenging system. But I can say in our work with or cancer survivors, people find ways to navigate the system, and they're ingenious. And once you can start tapping in to those stories, you learn. And I think of Amber's stories, those stories she's working with Alzheimer's care. And really that people become ingenious. They listen to one another and they say, now I know what I'm going to do. Now I know what I can do. We learn from those stories and we're inspired by them. And maybe the digital storytelling would help us.
I think I'd like us to do something about this very neoliberal personal responsibility focus in terms of well-being and caregiving, such that communities are resourced well enough to be able to support the families in their community as they're navigating healthcare. I mean, we keep telling mothers there are all these mental health and physiological health benefits from routine family meals, so you need to have more of them. Let us know how it works out. And then we don't know why they'll say families, but mothers are the ones who are hearing that. So just this expectation that if we give you the information, then it's up to you and your family to fix it. You're responsible for everyone in your house, and if anything is wrong and you can't manage it, we'll give you more information, and then you will manage it. And then if you don't, then, what can we say? So I think we have to, and I don't know that this is particularly unique to Appalachia, but I'd like to see us doing what we're doing with, improving the dialogue across institutions that we're doing with substance abuse, and branch that out into some other areas, realizing that families who are dealing with Alzheimer's are struggling unimaginably. So you have two partners, let's say husband and wife, and he has Alzheimer's and she's responsible for caring for that, but she's older, she's fading out in many ways, and she's responsible for that. And now she has this full-grown man who in many ways is not a full-grown man. And so there's no one to talk through bills with. There's no one to talk through what should we do about what that specialist said. Do you think that's the better person to go? There's no one to talk through and make sense of that with, and they need help. Getting to multiple doctors, they need help. Being able to do something with all of the information that they get, they need help. Remembering the pills that they have to take. So you have, I'm thinking of your multiple morbidities work, and
What we call cohabitating morbidities.
yeah, where we have sick people taking care of sick people
Under the same roof.
under the same roof. And so then, and for purposes of my research, we see that so often that it's women who are doing that, sick women who are taking care of sick family members.
And multiple generations.
Yes, that's right. And we just want to say, well, let's give them information. Here's what we'll do. We'll get really good at giving you info. See ya when you're healthy or something. I mean, it's heartbreaking. I mean, it's heartbreaking. The work on this project that I'm doing that is using stories of Alzheimer's to help people who are dealing with Alzheimer's know how to navigate particular situations. I mean, they may be delusional on a regular basis and think that there is someone outside trying to get in. And every day we're instructing the person who's doing the caregiving to go along with this for a moment until you can distract the Alzheimer's patient. So pretend with him each and every day that there is someone out there for a minute, because you can't argue with an Alzheimer's patient because they can't process the argument. So you're not going to get anywhere. So just, sort of play along, hide the keys. I keep asking my mother why they will drive to the store. He will not see her because she's gone another aisle. He doesn't remember why he's there. So he leaves and leaves her there. He doesn't remember, he's just so unsure, I think, that he just wants to go home where he knows, his surroundings. And so we say, Mom, you can't give him the keys. And she's saying, who can remember that? Like, I am barely getting the two of us to the store with the list and some money all at the same time. Now, in addition to answering his questions 50 times a day, you want me to remember to get the keys from him. When he's going to say, what's the big deal? What are you talking? I'm the one I got the key, right? And so we send them home with information without an awareness of how deeply complex and troubling these kinds of things are. I mean, it's their lives are the Alzheimer's patient and the caregiver's lives have changed radically. They're no longer the person they used to be, and that means the caregiver no longer has the life they had, and no longer has their own identity either, because their identity is the caregiver.
I would like to take, so many times our weaknesses are our strengths, and our strengths are our weaknesses. And the story that you're telling, the frustration you're expressing is very real. To me, it's like with 70% of the people who are served in my program are people who have some form of dementia or some sort, and we work with them, we work with their caregivers, we provide the solution to many of the problems that you're describing, but that is in this one little place in the middle of nowhere. And PACE is not an option that's available to everybody. So I'm not going to go into that so much as I am to thinking about families themselves. Families, I think that one of the things that Appalachians do very well is taking care of is bringing that family strength, to health, and if we have, it's like as I'm watching the generation, my mother and her sister and other people age and reach the end of their lives, I'm seeing my cousins and my other relatives, because I live in the same place where I was born, and sort of an exotic flower, I suppose, that couldn't survive anywhere else. But it's like I watch all the family members come to their health, and they care about them. They stay in tune to what's going on. My brother, who was someone who drank 2 cases of beer a day for decades, sobered up in 2008 and is now taking care of my mother who has dementia. And he's doing a very good job of it. She took care of him, now he's taking care of her. They live next to me. Well, then I've got an aunt who lives across the road who can no longer walk, but she's got a granddaughter who's an occupational therapist who's coming in and doing all sorts of exercises and teaching, and is coming to my mother and saying, okay, Tony, you need to get this therapist or that person from home health in here to check on her. It's like the families are aware of each other's problems, they support each other, and they do it until death. And I think that's a strength.
It is a strength.
Yeah, for us.
And it can kill people early. So when you say until death, you better believe it.
Yeah.
Because we know, I can't remember the statistic, I've lost it, 80s, 90s. The percentage of caregivers taking care of Alzheimer's patients who die prior to the Alzheimer's patient, because it's killing them. So yes, it is a strength. I think it is a strength, and it's killing them also, and they need help.
Well, and this point that we've got to come back to, one of my biggest concerns of having lived in Johnson City since 2003, grown up in Appalachia, has become, and this is what Amber's already touched on, and Tony's great story has hinted at, is something that we've talked about in our research of this, again, this cohabitating morbidity. We have not even started grappling with, as our population continues to age, that it is, and we found this among our cancer survivors who said, that we interviewed, who said, I can't afford to be sick because the husband has lung cancer, because the son is a recovering alcoholic who and I think Tony just really in such a powerful way talking about, thank goodness that they almost staggered their conditions. But we're talking about a population that within the individual may have multiple morbidity. And
right.
Now, so you have multiple people living within the same holler or the same house, each person with multiple conditions that are taking care of one another, and you hope that you can kind of seesaw back and forth. But really, is that altogether an option? Because someone eventually collapses. Someone does.
And I'm going to let you guys think about that for just a minute. Because I want to see if Rebecca wants to get in on this question before we turn it over.
I would. So there's a lot happening. So I'm going to kind of roll a couple of things together here. What I think we do well in Appalachia is we have profound examples of activism, of people who step up in their communities and make things happen. Whether it's starting a nonprofit, whether it's back years ago with Mary Breckenridge and Frontier Nursing Service, Beulah Hall and Mud Creek Clinic, all the different churches who have clinics after Sunday service or Wednesday, who are stepping up to do what they can. And so I think we can draw on that spirit and on the strength and on the leadership that we have to start to fill these spaces with caregivers and with families, and to figure out better ways to do integrated care, and to link with groups that are fighting environmental degradation that also leads to other health issues that contributes to chronic disease, and these things that are so much more than just something individuals and families can cope with.
That was actually one of the things that I was thinking about too, in terms of strengths, is just leveraging, all of the faith-based institutions that have different, medical missions and things, outreach that they do. We do a good job of that. We can do better. We can leverage that even more. And I think the thing that needs to change the most, the piece that and perhaps it's because I'm not from here that I've been able to see this more clearly, and even more so in recent years, is that Appalachians have largely developed pretty low expectations for health. And I think that's a crisis that has to be addressed, and it needs to be addressed by having multiple sectors working together to try to change the culture of health, to have people believe that good health should be an expectation. It is achievable. And then by doing that and having people expect that, those resources will come. So I think changing that perspective and expecting good health is something that's very much needed here.
Thank you. All right, with that, we're going to wrap up this discussion and open it up to questions from the audience. So,
all right. First of all, thank you all for your time and for sharing your experience. I really do appreciate it. I'm from Kingsport, Tennessee myself, born and raised. I'm not too familiar with the church clinics and some of the other things we talked about. I'm sure that there are some around. I've been in this area for almost 30 years, and it's not something that jumps out at me. So like Dr. Fletcher, I think that you had brought that up. Because this was kind of my point. I think the running themes that we've been talking about in this area are the economical problems, educational and geographical, stemming from the availability of the size of the communities, the access, and the income. And so I just don't understand, if these are the problems that we're facing with, then what are we doing to tackle them? I mean, honestly, really deep down in this community, in this area, what are we really doing? I mean, I know people talk about it all the time, but can we not support like traveling medic trucks, free clinics? More so than what's really happening. Legitimately, is this feasible to have traveling medic trucks, free clinics that could kind of 2 in 1? Why not? Is my next question. Real question. And I'm just going to leave it at that.
I just wanted to say one other thing about what will fix our system is to have universal access to health care, so that that will create a market, so that there will be sufficient, so that every community can afford to pay the providers that they need to be healthy. We also need to have, you mentioned the health and education and occupation or employment are 3 legs on a stool, and the stool cannot stand unless they're all in place. And I've been working for 40 years trying to solve the problem, and I'm gonna be dead, and it's still gonna be here. But I hope you can fix it.
Can I say let me say one more thing. There's like, the Welcome Center that was built on exit 4 on Interstate 26. I don't know how much money was put into that thing, but what good is that thing really doing, honestly? And then there's another park that they're gonna build in Kingsport. I mean, if health in this area is so poor, we are all so poor, then why? How do we have this money to build things?
Well, and I want thank you for coming out. I mean, let's face it, if you did not come out, we would be up here talking to one another. So I appreciate you thanking us, but thank you. Something that I want to say, and I'm really hoping someone will bail me out because I'm not going to be uplifting here. I know, I'm sorry. But I am concerned about our fragmented system. I'm concerned that we put so much emphasis on, as you say, church clinics, except I know that 90+% of Appalachians identify as Christian and Baptist, but here's the thing, that doesn't mean you necessarily go to church. And we also know that people can lie about religion. So there are people who are not going. And what if you are not of that faith-based community? Are you then left out? I'm concerned about mobile health care. That, and we touched on it, continuity of care. So what? You get diagnosed, you get your results back, then what? I'm concerned about RAM, and I know that they're doing great work, and they try to work on referrals. But again, the problem is continuity of care and this lack of relationship that keeps people in the system. So I think we're doing a great job. What Appalachia has traditionally done is that get her done philosophy, and we're going to piece it together. And I don't care how it works, but we're going to maybe, put some wax on it and wrap something around it and hold it together. But that ultimately doesn't help. And especially as our population continues to age, as our families continue to be burdened, I think the system is just going to keep crumbling. Someone bail me out and make this positive go.
So I can't help but think about the root of your question. To me sounded a lot like, how are we allocating resources and who's making those decisions? So I'm not sure if the governing body that decided to put a welcome center on exit 4 was the Tennessee Department of Transportation or the Sullivan County Commission, but regardless, it's highly likely that an elected board made the decision to allocate those pennies to that project. So I think a solution is to elect more empathetic leadership, to elect a leadership whose bottom line is quality of life improvement and not dollar signs. That's hard to break that mold.
Well, I think that's where we're at.
Yeah, I think it's exactly where we're at.
I mean, honestly, if we're talking about health and wellness in Appalachian, if we're talking about really doing something for our people here, then that's where our focus needs to be at.
100%, that's where our focus
okay,
is.
I mean, yeah, all right.
I agree with you. I think, and I'm there. I've run for office. I've knocked on doors. I've answered those questions from constituents. And, some of the first two questions you get can be significant barriers to their trust in you, which is, are you a Republican and where do you go to church? And if you don't answer those in a way that's satisfactory, then you have another mountain to climb, which is proving your competence, proving your training, proving your lineage, proving your commitment to the region, and it is not easy. And
None of which you have to necessarily prove if you answer the questions correctly.
Correct.
That's right.
Correct. If the answer to those first two questions had been what they wanted to hear, it wouldn't be so difficult. And of course, I can't, I don't want to apply that standard to every household's door that I knocked on, because some of my constituents are in the room tonight. But I think that...
Thank you for coming.
And thank you. I hope you feel like your tax dollars are well spent. But to get that type of person to run for office is a big challenge too, because it is face a system that moves at a glacial pace and face a system that is so heavy and hard to shift towards improved quality of life. So I appreciate your question, and I think it's rooted in power and money and who has it and who's making those decisions.
And I would throw out too, it's not a local problem. You know, I think that these are problems that have to be solved on a higher level, on a state or I mean, localities can do things like have a van that goes from place to place and provide, gives medication samples to people who have illnesses, but that's about the extent of it. And that's just a piecemeal thing. We have to have access to health care, and the way to do that is through universal public health insurance. That is the same for everybody across the nation. And then you might see some changes, because right now the places Appalachia is in many communities, they're dying. They're not going to get better. There's nobody investing money in those communities for people to get jobs or to, when you graduate, you don't go into a job. You can't earn money. You can't pay a doctor. So you try and get disability. I've been on this health council for the Appalachian Regional Commission, which is on the chopping block.
Yes.
If Trump's budget goes into place, but But one of the things that the head of the Appalachian Regional Commission said was that congressmen can see that there's a trend in the counties in southern and central Appalachia with a high proportion of people who are on disability who are between the ages of 16 and 64. So that means they're not working. That means they're on the dole. These are people who are not being a contributing element in the economy of the country. Mm-hmm. So they're not worth much. And what they wanted to do was to find ways of stopping disability support payments going to people who are between the ages of 16 and 64. If that happens, then, you might have more people participating in the economy, but they're not going to be in Appalachia. They're going to have to migrate out of the region. Is that the solution we want? It's a solution that people were faced with in the 1920s and 30s and, even into the 70s. But, for God's sake, we can do better than that. This is the United States of America, and there's a lot of money out there, and our society can do better by the people who live in it.
Yes. And us.
I think someone's running for office.
Another thing I wanted to mention is, what Tony said about it not being a local problem is true. It's not just a local problem. It's a larger national problem, and it's a systemic problem that we're not going to solve overnight. But one thing I think that people in the area do not take advantage of is the ability to contact their representatives and advocate for their own health care. And I think that wraps up into things we've talked about with storytelling as well. They don't hear the stories of why we're not working in this area, or why there's widespread opioid abuse, or what cancer is doing to families, or why families are so collectivist and taking care of each other. They don't understand the culture, and they don't understand the outcomes of health and poor health in this area because they're not here. They're not on the ground doing the work. They're not seeing it every day. So I think if there's maybe one thing that I could say would maybe benefit this population, it would be get more involved and tell those stories so that maybe they do start to understand and they do start to see why it's so important, maybe not to build a welcome center, but maybe to build a healthcare center instead.
Kelly, upstairs back there.
Good evening, thank you. I just had a general comment. One of the things that stood out to me in some of the conversations that maybe wasn't expressly stated this way was issues of power. And so I think that really comes to play in Appalachia, in particular when we talk about things like people need to advocate for their health care, or people need to do this, or they need to do this. Power is, I think, something that's not always spoken about really expressly, but people don't always know how to advocate for their health care. So I think that's something that's important to consider. Even people who are well-educated or who have different resources or things like that don't always know how to advocate for their health care. They don't know how to ask the questions because they haven't ever seen themselves maybe in a position of power. And I think this can be a problem in rural cultures generally, where doctors, for instance, we talk about physician distrust and things like this, but where doctors have always held a higher position of power. And this goes back to the earlier discussion about why people maybe want to talk to nurses. Nurses bridge that gap. They are seen, I think, a little bit more as a working class person than necessarily a physician. So the nurse may be someone you run into at the grocery store in his or her sweats and, looking like you do when you roll out of bed, but the physician is someone who lives on the hill. You know what I'm saying? And so it's a little bit of a different thing. So I think power is a really important thing to think about. So those of you, I think, who are doing research or people who are thinking about that, I think power gets understated in some ways, but in some of the research that I've worked on with Katie Baker, with Megan Quinn, both of them, that's come up in a lot of the stuff that we've seen as people talk about that again and again. And, I don't know how to ask doctors this. I don't know how to ask them repeatedly. If a doctor says, no, you need to take this, then you're supposed to just acquiesce and say that's okay. You're not supposed to come back again and again and say, well, what about this? What about this? It goes back to managing appointments and things like that. So I think that becomes a real thing when you don't know that you have power as a consumer and as an advocate. Same with contacting your representatives and things like that. To not understand that some people really have just never been made to understand that they have significant power in those ways. It's just a thought that I had when I'm listening to the discussion. Thank you.
Hey guys. So piggybacking off of, what was your name again? What Kelly just said. We've talked about a lot. It's been awesome. So first, as an Appalachian, I would like to point out that it is my firm belief that the Appalachian culture is strongly rooted in independence and subsistent living, which means that we take care of ourselves, and we don't typically rely on other people to take care of us, right? So then here comes this paradigm, this new world of, we have these doctors now, we have these new illnesses, these are things that we cannot take care of, therefore we must now go to the doctor. So then you have, and you guys have painted this story for us this evening, that, so then people start going to the doctor, taking these medications, hoping that they're going to cure something. Inevitably, a lot of chances, they don't cure what they thought. And then you have this distrust that we brought up between patient and physician. In addition to that distrust, there is still a lot of storytelling that happens within the family dynamic. Okay, so the information technology, these millennials are coming out. We have access to the corruption of the insurance companies. We have access to the corruption of the financial relationships between the medical companies and the insurance companies and the physicians, and how all of that is orchestrated in this fill-in-the-blank disastrous system that we have as a medical system. That was my opinion. Sorry, I inserted that so firmly. But yes, so there are several different reasons why I feel that Appalachians specifically do not trust their doctors. It's not just the doctor who happens to be signing a petition, if you will, saying, yes, I will follow the rules set forth by the medical companies. Yes, I will follow the rules set by the insurance companies. Yes, I will choose to prescribe you things and to tell you things that I don't even personally believe because that is my job. That leads to distrust. But in addition to that, the actual medicines lead to distrust. And this brings about one of the solutions that we discussed tonight was the RAM, Remote Aerial Medical. For those of you who have never heard of that, it's a beautiful thing. I myself participated in it for almost 10 years. And the reason I chose to participate the Remote Area Medical was because I did not have to show my ID. I did not have to be a U.S. citizen. I did not have to have insurance. I did not have to tell the truth. I did not have to do anything but show up in line and ask someone's opinion. And because they were doing it for free, they were not in a contract to tell me what they had to tell me, which is not what I wanted to hear. They were able to provide me with the truthful and honest care because of the situation that system provided that trust. And so in situations, I would find a diagnosis or a potential suggested diagnosis from a doctor at RAM, but then I would refuse to go to a regular doctor because then it's locking me, how I felt, into a system that I didn't trust. So I guess I just wanted to point that out, and just say, like, thank you for covering a huge spectrum of the problems and potential solutions that we face. And there was one other thing that might actually open it up to a more conversation piece, which is about addiction. I think that could be another potential solution for the way that we approach care. Addiction is not just, and we can all acknowledge this, right? Addiction is not just sex, it's not just drugs, illegal drugs, tobacco, alcohol. It is also sex, sugar, television, right? There are lots of things that we are addicted to on a daily basis as a result of trying to cope with this changing world. So those are conversations that I'd like to see more of personally. So again, thank you so much.
Thank you. I think we have time for one more brief question.
Good evening. Actually, I have a lot of questions, but you said brief. So I guess we talked a lot about technology and the older generations. With that, I have the question, are we still providing resources for those who don't use technology or who are not familiar with how to navigate the technology that we have today? I know for my grandfather and my grandmother, they're sick, so they confide in my mother and her brothers, their sons. But how do we give those resources to those individuals who don't know how to navigate through that technology?
Look at me looking at everybody else. Yeah. She's like, good question. Knock it out.
I'm looking at Tony specifically, actually.
I'm looking at everybody down the line.
I don't know. I'll tell you what. I have literally tried, to give the technologies and the instruction to my mother, my brother, other relatives, and they don't want it. They're happy with their lives as they are.
Well, and it puts that fear too, or that distrust.
That's true.
Okay, I'm confiding in my family members, but if they can't give me the resources themselves, then I have to go and search it myself.
Yeah. I will say that sometimes I get phone calls where people are in a discussion and they can't, they've heard something, they want to verify it, so they call me to get me to do a search.
Well, and I hear that, we talked about storytelling and experiences, and I think for those older generations, I think that's what they do. They search out for communities and those experiences those individuals have to find some kind of information out.
That's true, absolutely. You had a list? Did you have a list of questions?
I do. I really
Haley, I'm going to say, I love that question, and I have no real data to offer, but that's not going to stop me from answering. Is that I have just kind of two thoughts. Number one, I was thinking about, wow, I remember one time I was at a clinic where this was in a situation with a bilingual or a family where the only people who were bilingual were the young children. And so the preteen daughter was expected to translate regarding her younger brother's health to the mother. And you think about this kind of what this is doing in terms of health and trust within the family, and I don't want to divulge because I'll burden other people. But what I'm struck by this really great question is, what is that doing in terms of technology? If I'm older, for example, or cognitively impaired, and I have something I want to search, but I don't know how to, what does that do to the power dynamic? Yes.
I mean, some individuals don't have those family members
Am
that
I
know how to
relying on my
navigate that.
younger family members? But what does that do with power dynamics that Kelly brought up? What does that do with issues of trust and confidentiality? And I just, that's all I have to say is that, good question.
Questions that lead to more questions. But unfortunately with that, we're going to wrap it up. We are out of time. So thank you all very much for your questions. Thank you for joining us in this conversation about such an important topic. I hope your conversations don't end here. I hope you continue to have them with your peers, with your academic communities, with your community members. It's very important to continue to do that. Also, I want to give a huge thank you to the Department of Communication and Performance and the Research Development Council. The department has been great to work with, and none of this would have happened if it weren't for their dedication and their passion. The faculty here, if it weren't for them, this wouldn't have been able to occur. So thank you very much, and also thank you so much to the panelists for coming out tonight to talk about Appalachian health, their research, and their practice. Thank you.